and speaker from Lafiya Nigeria in the person of Fatima Musa. So she is the program manager for Lafiya Nigeria in Jigawa. Lafiya Nigeria is a non-profit dedicated providing women with contraception, focusing on optimizing cost-effective solutions, making them competitive with GiveWell, a top charity in terms of cost effectiveness. And Fatima is a humanitarian enthusiast with outstanding experience and innovative contribution to various interventions in northern Nigeria. She is passionate about human rights and sensitization on issues affecting the minority group. She is currently working with Lafiya Nigeria as a program officer in Jigawa State, leading a team of 45 Lafiya sisters to ensure cost-effective access to contraception so as to reduce maternal mortality. Please join me to make welcome Fatima Balarabe.
As introduced, I'm Fatima Balarabe Umar, a program officer from Lafiya Nigeria, Jigawa. And my discussion is going to be on optimizing cost-effective solutions for contraception. We are going to get insights from Lafiya Nigeria. I'm glad that the first speaker also mentioned family planning, which basically will be, we are working on the same field. Okay, as we can all see, cost effectiveness and why it's such a powerful metric. We are going to link this with the impact that Lafiya Nigeria is currently making. As we know that cost effectiveness is one of the measures, a powerful metric that has been used to measure the impact of a particular intervention worldwide. And it is also a metric that's used to evaluate the efficiency of an investment, as I already mentioned. And there are so many reasons that are linked to that. One is transparency and accountability, resource optimization, and many others. So our experience with creating a cost-effective are many, but we streamline, in the course of this discussion, we streamline to 3 points. In-depth research and analysis. Prior to commencing implementation in Nigeria, Lafiya Nigeria conducted a pilot study in Jigawa State for the period of 6 months, and before we came up with this idea, implementing the idea. So we conducted a comprehensive research to understand the problems, the gaps, and the drivers, and we also evaluate to see how we can start. During the pilot period, which was 6 months in 2001 in Jigawa State, we identified the gap in family planning contraceptive, a stockout, majorly in northern Nigeria. And why we selected Jigawa State in the first place for the pilot study was because the CPR in Jigawa then was very low, it's still low. And within the period of 6 months, we were able to provide a contraceptive, Sayana Press, 2,400 doses within the period of this 6 months to cover the stockout and the gap as well. Leveraging existing resources. Seeing that there are a lot of problems, bigger problems with limited resources, for example, like us at Lafiya Nigeria, we had to leverage on the existing structure, focusing on the health workforce that is already existing, civil servants who are from the category of nurses, midwives, and CHIOs. So we leverage their experiences, and being civil servants already working in facilities across the state, we leverage on that and work with them to procure the contraceptive and then distribute in the community. And the third one is continuous improvement through metrics. As we started from Jigawa, there was an expansion, and also through our metrics, we focus on cost effectiveness. And it's one of the reasons we leverage the existing structure from the government, stakeholder, and then including the volunteers that we refer to as Lafiya Sisters. And these are GiveWell top charities, some of them that we see for now. We have a malaria consortium, and they they provide anti-malarial drugs to children of certain age, and use of $7 per treatment, which is highly cost-effective. Helen Keller as well, $3,000 to $5,000, saving lives using the by providing vitamin A supplements. We also have new incentives, which provide cash for routine immunization and vaccination as well, and they save life using $3,000 to $5,000 is being spent, and $1 to $1.3 being spent per child. Then we also have AMF, that's Against Malaria Foundation, as one of the top charities as outlined by GiveWell. And looking at this, Lafiya Nigeria, going back, identifying the problem from the onset, we also identify globally, there's every 2 minutes a woman dies from giving birth. It's a global problem. And over 270 women want contraception but cannot access it. Nearly half of all pregnancies are unintended, 121 million annually, and that's global. Then coming down to Nigeria, and there are 40,000 Nigerian women that die each year from pregnancy complications or pregnancy-related issues, and only 11.7% out of the 106 million women in Nigeria that use contraception. And yet, 25% of Nigerian women want contraception but cannot access it. So this is the problem identified by Lafiya Nigeria, and this is Nigeria generally. But our focus and implementation is currently in 3 states, hoping to commence implementation in the 4th state this month. These states are all in northern Nigeria. As I mentioned earlier, we started with in Jigawa, having the lowest CPR rate. Then we moved to Kebbi, Sokoto, and now looking to start implementation, currently on the process in Kano states. That's currently, but looking to expand in the nearest future. And this is our theory of change. After identifying these challenges, these issues that the community is facing, and then outlining the target location and target areas, we, as I mentioned earlier, we leverage the existing structure, including healthcare workers or healthcare providers that are currently working in facilities. So we upskill these healthcare workers. We refer to them as Lafiya Sisters. That's the volunteers from various facilities. So we upskill them and train them on family planning, counseling, and administration. And we also procure this contraceptive. Currently, we are focusing in just a single contraceptive, that is the DMPASC Cyanapress, which is injectable and easily accessed and used. And then after doing this, the Lafiya Sisters, after receiving this training, they provide information. Let me go back a little to mention something on the Lafiya Sisters. These are women that were trained earlier, prior to being engaged by the state government by a program and intervention between 2017 to 2012 by a program called Women for Health, funded by FCDO in 7 states then. So Jigawa happened to be one of them, and when engaging the healthcare workers, we work together with an indigenous organization that's Nana Empowerment Initiative that work together in implementing the project of Women for Health for 7 years in those states. So we also work together with the government stakeholders in engaging this, while engaging these Lafiya sisters. We selected more than 50% from those that benefited the Women for Health program. And this is why we selected, because the reason why we selected them is because they are originally selected from rural settings in the local government across the states they are implementing, including Jigawa and Kebbi then. And afterwards, there was an agreement with the state government where they were absorbed and engaged as civil servants. But going back to their various local governments, because they are sourced from rural areas, they are to go back there and provide these services. So being there, and one of the things we have from our model is it is female-led, it is community-led, and community-oriented as well. As such, we use them, and they go back to their facilities and the community to provide services in the community as well. And as such, the result of that, it leads to a higher contraceptive use and reduces unintended pregnancies. That's one of our goals. And generally, it's leading to reduction in maternal mortality and morbidity as well. And our impact so far to date, targeting the unmet need, so far 40,172 Sayana doses have been distributed in the course of this period across these 3 states I mentioned, Jigawa, Sokoto, and Kebbi. Then we currently have more than 120 Lafiya sisters that are working on family planning, counseling, and administration daily, both in facilities and in the community as well. And prior contraceptive use, women served, 35% of the women we serve currently are first-time users. They've not used any method of family planning prior to what we do. 38% level of family planning knowledge increase after training this particular Lafiya sisters that we work with, since we provide a training on this prior to engaging them. The drivers of our impact, this is what I mentioned. We engage healthcare providers existing on the current structure, which also falls back to our cost effectiveness, since we have limited resources. Sayana being used, using Sayana Press is highly cost-effective and injectable contraception with $0.85 per dose provided. And we do direct distribution. That's the channel is working from the organization directly through the state government, directly to the Lafiya sisters that provide these services to women in their various communities. And the result so far, it's currently 20 times more effective than cash transfer, and by 2025 will be 53 times more effective than cash transfer. And it's also competitive with GiveWell's Chop Charities, that's some of which I mentioned back. And the current cost effectiveness of the intervention is $19 per unintended pregnancy. And this is all done. We recently had an independent evaluator that evaluated our program, that's routine priorities. And this is coming out from the evaluation. And these are the key statistics currently in Q1 of this year, Q2 and Q4 for cost per daily averted, maternal daily averted, and up to cost per unintended pregnancy averted. As you can see, as it's going down, our impact will be going higher. And this means all this I've already explained: enhance efficiency, longevity, scale beyond a small project, and hoping to make greater impact. We are also looking at scaling our doses to 4 doses. Getting 1 dose at a time covers 3 months, but getting 4 doses covers a year, which also is definitely cost effective. It will reduce the cost of transportation and other things for clients. We also do SMS messaging, increasing scale of recruitment and economies of scale. I'm up. Okay. Then thank you very much. You can discuss this with me or later, or contact us via info@lafiyanigeria.org.
Thank you, Fatima. Now we'll be fielding questions from participants, and we're going to be taking the first 3 persons.
Okay, thank you for your section. My question is, during your statistics, you said 40,000 Nigerian women actually suffer from pregnancy complications. And then in your models, you talked about reducing maternal mortalities. And in your organization, it's more like just using contraceptives. So I want to ask, is it a way you will bridge the pregnancy complication part, or it's just mainly on the contraceptives?
Okay, thank you. Currently, as I mentioned, we are focusing on the contraception or providing contraceptives to women who need these services. And in return, it's going to avert unintended pregnancies, which in turn will also reduce the complications, as I mentioned, since it's a family planning method.
Thank you very much for your presentation. Please, I want to ask first, what is the meaning of Lafiya? Is it an acronym, or I don't understand what it means, so I want you to tell me the meaning of that. Then my second question is that I understand the fact that the problem you're trying to solve is a kind of a general problem, right, that women and all of that face in the society. So I really want to appreciate the effort of those that have actually presented earlier, and there's one thing I noticed. Most of your works are actually based like kind of regionally, kind of based or something. So what are you actually doing to expand to other states like Southeast? And that's my question. What are you doing to expand to other states, since this problem is actually a general problem? Thank you.
Okay, thank you for that. Your first question, Lafiya is not an acronym. It's a Hausa word. It's derived from Hausa language, meaning health. So that's how it was gotten. Then the second question is, you mentioned from me and other presenters that presented earlier, our focus target areas are in northern Nigeria or a particular region. Currently in Lafiya Nigeria, as I mentioned, our operations are in 3 states, looking to expand to another state, which is in the same region, recently. Then by 2025, we are still making researches on how to expand to other regions in Nigeria, not just a particular region. And we are going to work with the states that have low CPR. I hope this is.
Thank you.
Thank you.
Okay, thank you for your presentation. My question is, since you operate mainly in the north, and we know that there is a tradition or custom where having children in large quantity is something that is something they want. So how do you now convince them to do a new reorientation for them in this area? Because like when I was coming, even the driver that brought us, he said he had 11 children, and he told his wife recently that if she gets pregnant again, she's on her own. And I told him, "Sure, you are the father." He now laughed. And I said, "Don't you do family planning?" Then he brought out this issue of culture and tradition. So I know you face a lot of this. So how are you able to reconvince the people that this thing is good and is something that should be welcomed in the northern part? Thank you.
Okay, thank you very much. I believe I also had this similar question from the first presenter. Although our focus is in distribution, but we also provide counseling services to our clients. And before that, we also work with the government stakeholders, including the local stakeholders, religious leaders, traditional leaders, because they have influence towards this. So sensitization is one of the things we do, providing awareness during counseling and during visits to the gatekeepers on this. And this has worked, so far this has worked for us in some places, although it's still a work in progress. It can be eliminated within a short period, but we are working on it. Thank you.
Thank you, Fatima. Thank you so much.